So this episode is a little different. It's the beginning of Breast Cancer Awareness Month, and I want to talk about triple-negative breast cancer because it's largely been left behind, or at least that's how it's perceived. Unfortunately, what kind of gets left behind in that is what we call triple-negative breast cancer, or TNBC, because triple-negative breast cancer doesn't express the estrogen receptor, which is targeted by tamoxifen, or the progesterone receptor. It also doesn't overexpress HER2, the target of Herceptin. Because of that, since those are the mainstays of breast cancer treatment these days, triple-negative breast cancer has sort of been relegated, and often it just gets standard chemo and there's nothing special we can do for it. And that is not true. Your clinician may not be aware of it, but there are multiple therapies approved specifically for triple-negative breast cancer, some that have proved to be effective but are off-label. We'll talk about that in a bit, and others that are coming up through clinical trials right now. You can get into clinical trials for those, or hopefully by the time you're seeing this, they've already been approved. Just know that there are treatments for triple-negative breast cancer specifically, and your doctor should know about these. If your doctor doesn't, take the resources listed down below, take them to your medical team, and expand your option set. Now, triple-negative breast cancer isn't a thing, just the way breast cancer isn't a thing, just the way that cancer isn't a thing. There are many different flavors of triple-negative breast cancer. Because there's a tremendous amount of variation within triple-negative breast cancer, or TNBC, don't stop with just a diagnosis of TNBC. Go for further biomarkers. It's incredibly helpful. There are less well-known targeted therapy options for TNBC that your doctor may not be aware of, but you can exploit. So, for instance, you can ask for a more detailed determination of HER2 expression. Now, angiogenesis inhibitors like Avastin are commonly prescribed since clinicians understand them, and they sort of use them when they don't know what else to use. But they do very little to help. Trying to keep blood vessels from growing in doesn't seem to make a difference. Instead, immune checkpoint inhibitors, or ICIs, a kind of immunotherapy, has been very successful, especially in combination with drugs that stress the tumor. They also have significant side effects, and you have to have the right kind of tumor, particularly PD-L1 high. So importantly, recent research shows that excessive removal of lymph nodes near the tumor, A, doesn't benefit survival rates the way people thought it did, and B, can undercut the effectiveness of immune checkpoint inhibition immunotherapies. So I want to specifically address this to you. If you've already had the surgery, if those lymph nodes have already been removed, please don't stress, everything is okay. It's not a huge issue.